Hi, everybody. This is Anne Marie Hughes. I am a 10-year pancreatic cancer survivor, thanks largely in part to this lady here, Dr. Ursina Teitelbaum from University of Pennsylvania Cancer Center. And Dr. Teitelbaum has been following me for years now at Penn. She is my oncologist. And she's done an amazing job, not only on me medically, but just personally. Has been just a wonderful person who's been very supportive of me, which I think we all know as cancer survivors, we need desperately in times like this.
Having a rapport with your oncologist is really important because it's an enduring relationship. We hope very, very long-term relationship. And I think it really helps when you have trust and confidence in your oncologist.
Well, that's very true. I really looked for that in the very beginning when I was interviewing my oncologist. Certainly with pancreatic cancer, you know that it needs to be enduring. And you have been just absolutely amazing. I did turn down doctors and nurses, even nurses that I had met where it was not a good fit. I really kind of looked at it not only as a medical interview, but also kind of a business interview. I wanted everybody here to meet you because you are amazing and you're a wealth of knowledge. You've spent a number of years, obviously, in this field. And to that end, maybe you could introduce yourself to the audience and tell the audience a little bit about your background and how you came to be a gastroenterologist oncologist.
Yeah. So I wasn't pre-med. I actually was a non-traditional post-bac, and after working a couple years on Wall Street, and I went to University of Maryland. And I loved everything, as med students often do, and then gravitated towards internal medicine. And then when I went to University of Chicago, which is where I did my residency and fellowships, my plan had actually been to be a geriatrician. And I actually started the geriatrics fellowship and had already applied and was starting. And then I did 2 rotations in oncology. And I had that aha moment that this was actually what I was supposed to be doing. So I actually did both. I did fellowships in geriatrics and I did fellowship in medical oncology. Cancer is usually a disease of aging, so it was a good fit. And I worked primarily in GI cancers because those, even more so, tend to happen in older populations. Although I certainly, unfortunately, have plenty of younger patients. And then about 7 years ago, I boarded in palliative medicine, which is symptom management, because I do think that the better you feel, the longer you live. So if we pay close attention to patients' symptoms, I think they can do better with complicated therapies and live longer and better. So my husband's told me to stop boarding in things because I now have internal medicine, medical oncology, palliative care, and geriatrics. But that's how I found my home. This was a good fit for pancreas cancer because it often has a high burden of symptoms and it tends to be older patients. So about 75% of my gastrointestinal medical oncology practice is actually pancreas cancer in all stages.
You mentioned palliative care, and I tend to think of palliative care as end of life. And I think a lot of people do think of that way.
I think of the term supportive oncology because for some people, palliative care provokes anxiety. The problem is palliative care was always tied to hospice. And hospice was always tied to not getting cancer-directed therapy or chemotherapy anymore. But in fact, even when patients are newly diagnosed or they're getting treated, they have a very high burden of symptoms, pain, GI symptoms, nutritional issues. So it made no sense. And so there's been this big push actually in all of oncology to move palliative care earlier in the continuum. And we actually have palliative care docs embedded in our system, embedded in oncology. And that way, so when I see a patient now, I can focus on managing their chemo and the symptoms of their chemo and the counts. And I have a symptom management expert there to help manage all the other things. It makes it a lot easier. And I think it's much better care.
You mentioned that 75% of your practice is dedicated to pancreatic cancer and all spectrums. How many patients are kind of in the early versus late stage by the time they get to you?
Before we had effective chemotherapy, if somebody looked surgical, and only about 10 to 15% of people present when they are potentially surgical, which is sort of the big issue. Um, Surgeons used to take them to the OR immediately because we didn't have anything effective. And then we would try and give them chemo and radiation after to, sterilize the radiation, the surgical field in case there were any cancer cells left behind. And, chemo goes everywhere blood goes. So the goal was to prevent any little tumors from trying to set up shop. But now, since 2010, we have not one but two effective chemotherapy combinations. So the real push for us has been to push them sooner. And in that continuum is something interesting because there is not there's a small but real fraction that we now call borderline or potentially resectable, in that they don't look like they're surgical up front. But our hope is that if we give them aggressive chemotherapy and then sometimes radiation, we'll be able to pull those tumors off the vessels or make them respond in a way that the surgeon can take them to the operating room. So partially, we're trying to increase the percentage that are locally advanced and surgical at presentation. And there are several trials ongoing up and down the coast, actually nationally, to try and improve that chance for these patients. We certainly see the majority metastatic still, and that's where the difficult reputation of pancreas cancer comes. There are no current screening tests, and that's a problem. I often say to patients, because they're shocked when they come in, and I say, the problem is the pancreas is deep in the body, and there's a rich sort of network of lymph nodes and blood vessels. They're kind of like, they're a superhighway to go to the body. So you can have a tiny, tiny tumor that spreads, and it's really frustrating. So I know at Penn and other places, we're looking for blood tests to see if there's something for earlier detection. A lot of research in this arena. We'd love to have a PSA like we have for prostate cancer, for pancreas cancer. There's a lot of other things they're looking at. Is there any way, we do lung cancer serially for patients with a tobacco history. Could there ever be an imaging program? Hasn't looked all that promising yet, but who knows what will come. And there's some other very interesting things in the works for screening potential. And that's really the holy grail, right? If we can catch it early, then we'll have the chance to cure it more often.
Yeah, the other thing that is really big is genetic screening, right? And this idea of knowing your tumor and matching the chemo
So
to.
there's two genetics, right? There's the genetics that you're born with, your genes, and then there's the genes and molecular profiling of your tumor. So your genes are called germline, and that's important because about 5 to 7% of the population may carry a gene that increases their risk of developing pancreas and other cancers. And it's crucial to figure out if the patient in front of you has a genetic a hereditary cancer syndrome is what we call it, for two reasons. We now have some therapies that target those mutations, so there's a therapeutic advantage. Plus, we know everyone is not an island, they're a village, and we want to identify their family members. So that's really crucial. And actually, that's part of the guidelines now. Every patient should get genetic testing in a cancer risk evaluation program to see if they have carry the gene and their families at risk. Then there's the genetic molecular profiling of the tumor. We often call it sequencing. There's that ad campaign at Penn, The Cure is Within. That's actually what it refers to, that your genetics or the genetics of your tumor may determine the response. Unfortunately, with pancreas cancer, we don't have any really reliable mutations to target yet. That's also an area of very active activity. And that is something I dream about. The reason we want you to get the testing, though, is what we don't know now, we may know later once we have the full sequencing of your tumor. So we may learn of mutations or findings that are targetable in the future. But our goal is that there may be targeted therapies that aren't chemo. Chemo is still kind of a blunt tool, right? It targets the cell cycle, the growth of the tumor. And they've even done these things where they take your cancer cells and they put them in a petri dish and they try different chemotherapies against them. And then what they predict will work in you doesn't work, and what they predict won't work does work, because, we're not a petri dish, we're not a mouse, and there is an interaction between the chemo and the person. So that's been very frustrating, actually. Um, but there are targets, when you always want to have a mutation that has a targeted drug. So it's like a lock and a key that they will connect and turn it off. We haven't found that yet for pancreatic cancer.
So what's your view also on immunotherapy? I know that is
Right.
obviously very big in cancer treatment now, but it's also been very difficult when it comes to pancreatic cancer
So we
specifically.
know it doesn't work alone. That
Yeah.
we know. Um, I always have sort of this simplistic reason why it actually hasn't really worked in any GI cancers. And I think the reason, again, simplistic, your food isn't sterile. So you eat food, and the job of childhood is to learn how all those foreign things that you're eating, that your body process it. So when you eat, your entire GI tract is sort of like a big lymph node, because it's reacting to all this antigen, all this foreign matter all the time. So the way immunotherapy works is you take the brakes off the immune system and you hope it'll unleash against this cancer or this other. But in the GI tract, it's always activated. Your entire GI tract is like one big lymph node. It is always activated. So that's why pancreas cancer, colon cancer are so-called are so-called immune cold tumors. And so our hope is to figure out how to make them immune hot, meaning the immune system can see them. And so the majority of our trials are immunotherapy plus something that we hope will activate the immunotherapy against the tumor. You better believe that every patient that walks in asks about immunotherapy, and it's a bit crushing to me when I say that that's not a great option right now. Chemotherapy seems so old-fashioned, but it is still our best tool, and our hope is obviously to expand upon that. One of my colleagues is working actively on the CAR T, another form of cellular immunotherapy, trying to tackle pancreas cancer in a different way. So I think, we have a lot of different routes. Immunotherapy might not be the answer ultimately, but I'm hoping there's a lot of other avenues that will move the needle forward.
So let's talk about the front end and what you're seeing from patients, what their complaints were before they get to you, uh, and maybe what they could have been more alert to if possible.
We're looking at patients with a new diagnosis of diabetes within the year prior. They're actually looking at that internal medicine oncology world. Also, kind of a new depression, sudden onset, also increased in the year prior. These are common things, so it may not be something so obvious, but we're working with primary care to see if any of those findings would trigger a more intense workup.
Depression,
And then, huh?
you said depression, right? You were
Right.
talking about depression. I mean, that's actually something new that my audience may not have heard. But that is definitely something that I have heard in the past that could possibly be an early sign.
Yeah, and I think particularly if someone's never had an episode of depression, like a sudden onset of depression in, 50s, 60s, that's something, I would pay attention to. And then, the other issue we had with COVID, and I think is relevant to all, is unexplained weight loss. I can't tell you how many people say I was trying to lose weight and then I kept losing and losing and losing. And, we saw a lot of that happening in COVID, and patients were more afraid of COVID than their unexplained 25-pound weight loss. So they presented a little later. So I think if we always sort of say it's, most people don't really lose weight. So weight loss, I think, is a big one, an early one. Um, you know, um, Upper abdominal discomfort, I would say, and pain, uh, discomfort after eating. A lot of times before you develop jaundice or you're found to have metastatic disease, you may just have a sense of being unwell, a sense of pain, sense of something being different. And I think people need to be in tune with their bodies. I think it's particularly relevant if anyone's had a family member with pancreas cancer, because they may, even without a genetic underpinning that we know of, may be at a little bit of increased risk.
How early? I mean, I know it's mostly a disease of the elderly, but for everybody here, I'm not that old. Um, I am in my 50s, but how early have you seen pancreatic cancer?
Oh, it's rare, but I've seen 30s.
Okay. Is there
It's
any
rare.
about that genetic makeup of somebody that is presenting that early?
And we obviously evaluated, but we didn't find anything.
Hmm.
So it's troubling. We are seeing a rate of increase. I think you probably know these statistics with COVID data collection that kind of interfered. But I think we're due to be the number, two most difficult cancer. And they used to say by 2020, but I don't know what that statistic is anymore. And we're definitely seeing a rate of increase that goes beyond the aging of the population. So there is something out there that's contributing. It's concerning. We don't know what it is yet.
Do you have a view on what people are eating relative to maybe the outcome of cancer, processed foods, et cetera?
Possibly, I think also the country being heavier. I think
Hmm.
probably the association with obesity is even more clear than whatever what foods you're eating. But probably there's a link there, right?
We just don't have enough funding, and what funding we do have is very dispersed, like a lot of cancers, right? It's all over the place, so then the money's going in many different directions, and it's just not that focused. That's my view. But what's your view on funding and what we could be doing better to source that funding?
Well, I do think PanCan has been pretty effective at lobbying government to try and consolidate funding. I think, some of these moonshot efforts will help. You're right. There's a lot of silos at the different research institutions, and getting all of the research more consolidated to move it forward is important. I'm not sure what the answer is there. Everyone really is in their own labs to a degree. Unfortunately, it's evolved that way to an extent in the US with the way, NIH and other funding services go. I do think sometimes philanthropy at different institutions actually more directly supports the lab and the younger investigators who might not have the big established grants. So I'm not sure what the answer is there. I wish I knew.
Yeah. Now, and it's interesting to me, the more we talk about early onset diabetes, and I think about how maybe diabetic pharma,
Right.
companies that focus on diabetes, should maybe get more in the mix when it comes to pancreatic cancer.
Yeah, I think that might be a clever way. And then more collaborative research with general internal medicine, endocrinology, and medical oncology, NGI, gastroenterology. Those would probably be the
Yeah.
directions, including radiology, to see what ways we could identify earlier. Certainly, our GI colleagues are very important in this for us.
So you are a very upbeat person, and I think one of the last things I would like for you to do for our audience today is to talk about what kind of hope there is
Sure.
for pancreatic cancer.
So, I often, when I meet with patients, I was a history major, and I will often kind of write out the timeline. And, it's really been a tough cancer compared to other cancers because the pace of discovery was slow. The same issue as the cancer being deep in the body, it's been, difficult to get early diagnosis, and it's been difficult to treat. Since 2010, we have several regimens and we have new drugs that have just completely turned the course of the disease. We used to measure it in months, and now I measure survival in years, and sometimes years and years and years, even in those patients that are not technically curable because they can't have surgery. So it's a completely different ballgame. We have so many trials now. And so I'm much more hopeful. And then, as we talked about before, now that we're integrating palliative care, earlier and more often, those patients are much more treatable. They're better trial candidates because they're more well. So I'm hopeful, just what I've seen these past almost 12 years now. It's been extraordinary. And now we can, reasonably say that you're going to live long and well, even if you're not technically curable. And we couldn't say that before. Definitely treatable and lots of new options. A little bit of a hiccup with COVID. Definitely, a hiccup, but we're moving full force ahead now. And so I'm excited to see where these trials lead, and the pace of innovation, I think, is picking up again.
Well, Dr. Teitelbaum, thank you very much. And thank you very much from the bottom of my heart. So you're a wonderful person. And I'm very grateful that you did focus your practice
Yeah.
on her, and I'm grateful to know you. So thank you very
Well,
much.
my plan is for us to be together forever.
Me too.